Welcome to the American Liver Foundation's Provider Education Program, increasing your impact with multicultural patients on metabolic dysfunction-associated liver disease with the National Association of Nurse Practitioners and Women's Health. I am Ivory Allison, the National Senior Director of Community Impact of the American Liver Foundation. The American Liver Foundation was founded 48 years ago and is the nation's largest patient advocacy organization for individuals with liver disease. We engage over 5 million people each year through our robust education, support, and awareness initiatives and programs. As part of our commitment to the liver community, ALF offers a range of educational programs for patients and providers. You can find more information on our website. Thank you to our sponsor, Pfizer, for their dedication, commitment, and support of this program and the American Liver Foundation. And a special thank you to our program partner, the National Association of Nurse Practitioners and Women's Health. You can find more information about them at www.npwh.org. And we would like to recognize and thank our planning committee for curating this program. They've done a wonderful job, and we could not have done it without them. Thank you. We have a wonderful program for you featuring our wonderful, incredible speakers from across the country. And we have first up today, Blanca Lizaola-Mayo, the Medical Director in Liver Transplant Center, Associate Program Director, Transplant Hepatology Fellowship, and Assistant Professor of Medicine, the Mayo Clinic College of Medicine, and Senior Associate Consultant for Division of Gastroenterology and Hepatology at the Mayo Clinic of Arizona. Welcome. Thank you, Dr. Blanca. Take it away.
Thank you, Ivory, and thank you very much to the American Liver Foundation for inviting me today. I'm very excited to talk about this highly prevalent disease, and I also want to highlight all the amazing work that the American Liver Foundation is doing to create awareness and bring more information to our patients and our providers about MASLD, or what we used to know as fatty liver disease. So without further ado, I want to start to talk to you about a little bit more of an overview of what's MASLD and MASH, and where are we standing right now in 2024. So what I'm going to be discussing today and our learning objectives are the recent change in the nomenclature with the new definitions and changes in the epidemiology of MASLD and MASH. How do we diagnose this disease and discuss the diagnostic strategies and importance of determining fibrosis staging in patients with this disease? And finally, I'll touch upon a little bit about the treatment and what options do we have to be able to battle this disease. So as I just mentioned, we know that before, non-alcoholic steatohepatitis used to be the term utilized for patients with hepatic steatosis with inflammation in the liver. And normally what we used to do is to rule out any other potential causes of hepatic steatosis, for example, alcohol consumption, as you can see here, in women more than 20 grams per day, and in men more than 30 grams per day, which is considered heavy alcohol use, and also ruling out any other chronic liver diseases that can potentially cause hepatic steatosis, for example, celiac disease, autoimmune hepatitis, or hepatitis C, specifically genotype 3. But now we have changed this. The nomenclature has changed, and the reason for this is because we wanted to have a nomenclature or an explanation that readily explains what really fatty liver disease is, and also to remove the stigma around the words fatty and alcohol. So what is the new nomenclature? MASLD, which stands for Metabolic Dysfunction-Associated Steatotic Liver Disease, is the new nomenclature for what used to be known as NAFLD, or non-alcoholic fatty liver disease. And on the other hand, what used to be known as NASH is now known as Metabolic Dysfunction-Associated Steatohepatitis. I am sharing here with you the new nomenclature, which includes all the new terminology. As you can see on the far left, you have what we already mentioned, the metabolic dysfunction-associated liver disease, that is MASLD. Underneath, MASH, which is the one that we will explain a little bit later, which includes inflammation of the liver and is the one that can potentially progress to cirrhosis. We now have a new terminology that is known now as MASLD, which is a combination of MASLD plus significant alcohol consumption. And as you can see here, the alcohol consumption is considered, for example, in women, 140 to 350 grams of alcohol, and in males, 210 to 420 grams of alcohol per week, and in average daily, 20 to 15 females and 30 to 60 in male. So this is very important because it's something that we need to dig upon questioning our patients, establish a good relationship with them to really understand if they're consuming alcohol or not, because as we now know, it plays a significant role in the development of this disease. The terminology for alcohol-associated liver disease did not change. We tend to avoid the term alcoholic or this patient is an alcoholic. We normally use this patient has alcohol use disorder. Just the same way that we say this patient has obesity, this patient is not obese, trying to limit or remove the stigma around these diseases. Another specific etiologies of steatotic liver disease, as I briefly mentioned, drug-induced liver injury, normally seen in patients taking methotrexate, tamoxifen, steroids, for example, monogenic diseases, and miscellaneous that we already talked a little bit about it, and cryptogenic steatotic liver disease. So as you can see, the umbrella has changed now, which used to be known as fatty liver disease is now known as steatotic liver disease. And under this umbrella, there's a big variety of diseases that should be considered whenever we're evaluating a patient with steatotic liver disease. Touching upon a little bit about fibrosis and terminology around liver disease. So fibrosis is scarring of the liver, scar tissue that replaces healthy functional liver cells. And it's very important to understand that scarring of the liver is divided into 4 different stages. And it goes from stage 1, where there's minimal fibrosis, stage 2, that is the one that we need to start getting concerned, as we now know, and we will see a little bit later, that is the one that is related to liver-related outcomes. Stage 3, where we start seeing bridging fibrosis, and stage 4, cirrhosis or end-stage liver disease, which is irreversible. Cirrhosis is severe scarring of the entire liver, is the last stage of fibrosis. And as I already mentioned, this is the one that is irreversible. However, once a patient has cirrhosis, the patient can be subdivided into compensated or decompensated, compensated and decompensated. And hepatocellular carcinoma, that is the primary liver cancer, and cirrhosis being the most common risk factor for development of hepatocellular carcinoma. In the setting of MASLD, it is important to mention that hepatocellular carcinoma can actually present without having cirrhosis, just like in patients with hepatitis B. And we will also discuss a little bit more of this further along. So what is steatotic liver disease? Steatotic liver disease, as we already mentioned, is MASLD, is the accumulation of fat in the liver, 5% or more, and where we see no inflammation. We see fat accumulation within the hepatocytes, but we do not see inflammation. And on the other side, we have MASH, that is inflammation and cellular injury on top of the fat accumulation that needs to be 5% or more. And this is the one that we already mentioned progresses to cirrhosis. If we talk a little bit about the progression of MASLD, as you can see in this picture, when someone has MASLD, the healthy reddish brown tissue begins to become yellow, as you can see in the picture. Inflammation can occur as fat accumulates, and you can see how the liver changes and as fat begins to accumulate and the liver becomes inflamed. So why is this important? Because whenever we assess or we identify that a patient has hepatic steatosis through imaging, that means that the patient already has at least 30% of hepatic steatosis in the liver. But I want to bring your attention to the percentages down here, where you can see around 15 to 40% of the U.S. population currently has hepatic steatosis or fat in the liver. From this, 5 to 10% have MASH already, which we know that these patients can progress to cirrhosis. To give you an idea, normally a patient can progress one stage of fibrosis every around 10 years. However, remember that around 12% of the population, from 12 to 20% of the population, are considered rapid progressors. And these patients can progress from stage 1 to cirrhosis within 10 years. So it's very important to keep that in mind. And currently, as you can see here, once the patient develops cirrhosis, the risk to develop hepatocellular carcinoma increases from 1 to 2% every year. But as I already mentioned, bear in mind that patients with MASLD can actually develop hepatocellular carcinoma without having cirrhosis. This still is not part of the guidelines, but I assume that soon we will be seeing some recommendations regarding hepatocellular carcinoma screening in patients with MASLD that are considered high risk. So symptoms may occur, but they are really normally non-specific in these patients. You can see mild elevation of transaminases, abdominal pain, nausea, but as you know, the liver really doesn't hurt. It doesn't hurt. Many patients may have vague fatigue. So it's important to screen patients for this disease. And later on, as you can see here, in patients that have cirrhosis that become decompensated, and basically the decompensation from patients with cirrhosis come from something called portal hypertension, where the pressures from the portal vein are high enough that these patients start developing varicose veins in the esophagus that may bleed. So we need to screen these patients for esophageal varices, where these patients start developing ascites, fluid in the abdomen, in the cavity, which we will see later on, and as well as hepatic encephalopathy or confusion. Regarding hepatic steatosis and the rest of the body, it's very important to remember that hepatic steatosis, or MASLD, as the word now, or the terminology now explains, is the liver manifestation of metabolic syndrome. So MASLD is a combination, or it's part of what we know as a metabolic syndrome. And a patient that has cardiovascular disease, diabetes, prediabetes, insulin resistance, hyperlipidemia, chronic kidney disease, PCOS, sleep apnea. Remember to screen your patients for sleep apnea, and some malignancies. All these patients need to be screened for steatotic liver disease, and as we will see later, which specific patients should be screened for advanced fibrosis, that, as we already discussed, is stage 2 fibrosis. What are the symptoms of advanced liver disease? I already touched upon this a little bit, but jaundice, which is the yellowing of the scleras, for example, pruritus. These patients tend to have a lot of itching, and many times there are patients, especially in patients with cholestatic liver disease, that it's an indication for liver transplantation, as the itching is so severe that it really impacts their quality of life. Variceal bleed, as we mentioned. The ascites, as you can see here, free intraperitoneal fluid in the abdomen, which requires abdominal paracentesis. And in these cases, we can try diuretics to try to mitigate these symptoms. And we also need to bear in mind that this fluid can become infected, and this needs to be treated. And we need to do diagnostic paracentesis to make sure that our patients are not infected. Coagulopathy as well. We know that patients with liver disease tend to bleed easier, but we also need to remember that these patients also have a prothrombotic state where they clot quite a bit. And in the setting of portal hypertension, these patients can also as well clot their blood vessels in the abdomen, which is important to consider. Hepatic encephalopathy, as I already mentioned, and liver cancer. So in general, the most common symptoms of these patients experience is muscle cramps, which can be severe. We always need to remember that it's very important for these patients to follow a low salt diet. Many patients think that because they're cramping, they need to take electrolyte drinks, for example, and which this will cause is actually to dilute or lower the blood sodium even further down. So it's very important for these patients to follow a low sodium diet of less than 2 grams per day. Absent or irregular menstrual bleedings in women, erectile dysfunction, infertility or loss of sex drive, gynecomastia, normally seen as a large or tender breast tissue in men. Normally, this is also a side effect seen in patients on spironolactone, that is a diuretic that we commonly use for patients with ascites or volume overload, and spider angiomas as well. So a couple of interesting facts about fatty liver disease of MASLD. MASLD is the most common cause of abnormal liver function tests in the United States. We also know that it's expected to become the #1 cause for liver transplantation by 2030. It affects around 25 to 30% of the US population. And from this 20% have progressed to MASH or steatohepatitis. That is around 5% of adults in the US. And many people, most of people with type 2 diabetes actually have MASLD or MASH. And sadly, what we're seeing more and more is that in our children, the prevalence around 12% in the US in kids from 2 to 19 years old. This is a very famous paper from Dr. Januzzi that he published last year, where you can see the prevalence, the world prevalence of MASLD. And since then, these numbers have actually increased, and we're seeing higher and higher numbers around the world. As I already mentioned, 30% of adults, 10% of US children, and high risk of type 2 diabetes, where there are reported prevalence of up to 80%, and in obese patients up to 90% as well. Very important to consider this as well. So this is a paper where they wanted to talk a little bit more about the prevalence. And as you can see, based on different non-invasive tests, we can assess how much fibrosis these patients have. And these numbers are scary and are staggering, where you can see that the pool prevalence in patients with type 2 diabetes, as I already mentioned, like is up to 65%. And as I told you already, like there are reported numbers up to 80% in patients with diabetes. So we need to screen these patients for advanced fibrosis. What about disease disparities in the setting of MASLD? We know that residing in low resources neighborhoods may increase the risk. This is normally seen due to food insecurity or lack of whole foods or gardens, or as well, like normally, unfortunately, these patients tend to recur to just fast food or food that is cheap and highly processed. So social determinants of health impact of morbidity and mortality are extremely important. More likely to be in minorities, mainly in Hispanics and Blacks, and increase overall mortality and incidence of cirrhosis and cardiovascular disease. So as I told you, MASLD is an umbrella term where we can see now that there are different categories here: MASLD, MetALD, alcohol use disorder specifically, or alcohol-associated liver disease, specific etiologies, and cryptogenic steatotic liver disease. And what happens to me when I'm in clinic, when I tell the patients that I'm trying to explain what steatotic liver disease, what used to be called fatty liver disease, I normally end up using the word fatty, which is okay, but we need to normalize that word with our patients. But they really need to understand the etiology or the root cause of this disease, as this is reversible. But the important thing is that we need to be extremely aggressive about this disease to be able to make a change and really remove the fat accumulation in the liver, and number two, be able to remove the fibrosis as long as we already mentioned, is before cirrhosis or stage 3. So MASLD, normally seen in images, as I told you, 5% or more with microvesicular steatosis, and MASH with 5% or more hepatic steatosis, plus inflammation and cellular injury that is normally seen under the microscope as hepatocyte ballooning. Plus metabolic risk factors, which is important to recall these ones, which includes obesity or being overweight, as you can see here, more with a BMI of more 25. Also remember that there's a terminology called lean NASH, which I will talk briefly about it a little bit further along the presentation. Insulin resistance or glucose more than 100, a two-hour glucose challenge of more than 140, and hemoglobin A1C of more than 5.7, or a diagnosis of type 2 diabetes or on treatment. Hypertension or high blood pressure of more than 130/85, or the patient being on treatment. Hypertriglyceridemia or triglycerides more than 150, or on anti-cholesterol medications that are on treatment, and hyperlipidemia in males, low HDL in males less than 40 and in females less than 50. And again, patients are already on treatment. So we already talk about the different umbrella terms. Now, what about specifically Hispanic and Latino statistics, which are very close to my heart, as I am originally from Mexico City and have seen closely how this disease can be devastating and affect many of our patients. Like, for example, here at Mayo Clinic, we see a lot of patients that are Hispanic that have suffered from this disease. And many times it's for lack of awareness of the disease and lack of awareness of the things that we can do to change, make an impact, and make sure that we revert this fibrosis and we avoid liver transplantation in many of these patients, and also cardiovascular complications from this. So Hispanic and Latinos are disproportionately affected by steatotic liver disease. We know that nearly 1 out of 4 Hispanics have MASLD, compared with only approximately 1 in 10 Blacks. We also know that both Hispanic men and women have a chronic liver disease rate that is twice of the non-Hispanic white population. And in 2019, chronic liver disease was the 7th leading cause of death in Hispanics. Regarding MASLD, the #1 cause of death is cardiovascular disease. So we know that MASLD is more common in men in general. However, once women go through menopause, this risk or the rate of progression to cirrhosis, from MASH to cirrhosis, pretty much evens out, but is faster in women. Also remember, because we're seeing more and more of these patients with MASLD that we already mentioned, patients that have a diagnosis of obesity and undergo bariatric surgery and later on start consuming more alcohol, the progression to cirrhosis is more rapid, and we end up requiring liver transplantation for these patients. So also remember to remind your patients, especially those that have had anti-obesity surgery, to bear in mind that their alcohol consumption should be null or minimal. So what are the risk factors in Hispanic and Latino communities with the statistics that we already mentioned? Genetic background. Remember that us Hispanics have an increased risk of having this specific gene variation called PNPLA3. We normally do not screen patients for this genetic variant, but we just assume that a Hispanic with an environment that is increased risk, meaning processed food, lack of exercise, etc., we just assume that these patients are at higher risk. Lack of physical activity, metabolic syndrome, as we already mentioned. So as you can see here, 35% of Hispanics in the US have metabolic syndrome. 43% of Hispanics in the US are categorized as obese. Food intake, a diet high in carbohydrates, high fructose corn syrup, processed foods, processed meats, etc. All of this will increase the risk and will lead to metabolic syndrome and MASLD. So liver fibrosis is associated with long-term outcomes in patients with NAFLD. Fibrosis stage is extremely important, as we already mentioned. The most important thing is that when we have a patient that we have a suspicion that the patient has MASLD, we need to screen these patients for advanced fibrosis. That is that magic number that is stage 2. Mortality risk exponentially increases with increase in fibrosis stage. As I already mentioned, stage 2 increases the risk for strokes, heart attacks, and other cardiovascular complications. And cardiovascular disease, as I already told you, is the #1 cause of mortality. And of course, cost for these patients. So how do we assess or identify steatosis? I briefly mentioned that we have different non-invasive tests. #1, an ultrasound and a CT scan will be helpful just to assess if there's steatosis or fat accumulation in the liver. And normally these two modalities are good to assess steatosis when there's at least 30% of fat accumulation in the liver. This type of modalities will not help you to assess fibrosis per se. It can give you indirect markers that the patient actually has portal hypertension, for example, by seeing varicose veins or seeing different changes specifically in the CT scan, but it won't really help you to assess the amount of fibrosis or scar tissue in the liver. So what can you use to assess fibrosis or how much scar tissue the liver has? One thing that you can utilize is the MRI. As you can see here, an MRI is definitely more sensitive and more accurate imaging to assess the amount of hepatic steatosis, as it can detect liver fat content as low as 5%. It has been validated to assess dynamic changes in response to interventions. But remember, this type of imaging is extremely expensive. We need to make sure that the patient is going to tolerate it due to risk of claustrophobia. And if the patient has a pacemaker, then it's not MRI appropriate or compatible. We won't be able to do this. On top of this, I also want to add up that with an MR, we can do something called MR elastography. That is an excellent way to assess how much fibrosis the liver has, and is very sensitive in patients with MASLD. Remember that another thing that we can do is a FibroScan based on our current guidelines. If you have a patient that has or you're suspecting that may have MASLD, the first thing that you need to think is, I need to assess if the patient has advanced fibrosis or not. We talked about stage 2. Number 1, we will calculate something called FIB-4 score. That is easy, very easy to calculate. You just need the patient's age, ALT, AST, and platelets. And based on the FIB-4 score, it will tell us if the patient has likely to have advanced fibrosis, and those patients will need to be referred to hepatology. Indeterminate, where those patients will need a second non-invasive test to assess if they have advanced fibrosis or not, or ruled out. And the patients that are ruled out should continue to follow up with primary care physician and have lifestyle modifications and modification of all the other, or treatment of all the other cardiometabolic diseases. So what about treatment? Well, the treatment starts today or yesterday, actually. I think that's a very good term, right? Like the lifestyle changes that we need to do need to be for real. I normally recommend my patients, it's not just going through diet. I don't want you to go to a diet. I need to change you to change the way that you eat for good. This is difficult, right? And that's the main reason why there's so much obesity and there's so much cardiometabolic or metabolic syndrome in the world. So number 1, diet. Number 2, exercise as well. That definitely stop alcohol consumption. And my favorite slide, the coffee. So normally calories, what do we recommend to our patients? The recommendation is to follow a hypocaloric diet targeting 1,200 to 1,500 kilocalories per day, or negative 500 to 1,000 calories per day as well. Regarding diet, I think is one of the most common questions that I get asked is, what's the best diet that I can follow? We know that Mediterranean diet is one of the best diets that is out there, not only for MASLD, but also for cardiovascular health. However, what I always tell my patients is the best diet that you can follow is the one that you should comply with, and is the diet that you should change and really make those changes for good. Start with little tips. Do not drink your calories. Don't drink juices. Try to limit the amount of fruits that you're eating. Increase your vegetable intake. Try to limit the carbohydrates. Anything that is white tends to be bad for you because it's high in carbohydrates and refined flour, for example. So breads, pastas, all of these things, rice is something that we need to avoid. We need to be very cognizant about the culture and what our patients normally eat. We need to include this, because if I ask one of my Hispanic patients to start eating some foods that normally they're not on their diet or they cannot afford, we're not going to get anywhere. So it needs to be personalized and multidisciplinary approach to be able to be successful treating these patients. What about lean NASH? As I mentioned before, these patients also need to follow a hypocaloric diet, mainly focused on protein. What we normally recommend for this patient is to lose from 3 to 5% of their current weight. The important thing is not just weight loss. We need to focus also on exercise to decrease that insulin resistance, that diabetes, that main driver of metabolic syndrome, which will help us change the metabolism, number 1, and number 2, remove that fat from the liver. Exercise. The recommendation is to do 150 to 300 minutes of moderate exercise, or 75 to 150 minutes of vigorous exercise. And normally the exercise that we recommend is aerobic exercise per week and resistance training that can be complementary. Why is exercise so important? We know that the number 1 thing that is going to help us lose weight is diet. However, exercise is going to help us to decrease the insulin resistance, and number 2, maintain that weight loss. Very, very important. Same question, what's the best exercise that we can do? The exercise that we enjoy and we're going to be able to comply with. Alcohol. So abstain from alcohol use completely. This is normally a black or white like question for me. When I see patients that have MASLD or even MASH that have elevated liver enzymes, my answer is abstain from alcohol. And as I told you, coffee, my favorite part. So 3 cups of coffee per day will keep the hepatologist away. Remember that. What we normally know from coffee is that the best substance is the one that is caffeinated. There's no real research behind decaffeinated coffee. And also remember that it needs to be black coffee without adding all the extra happiness from all these famous coffee providers with whipped cream, etc. So 3 cups of coffee have been shown to be beneficial for the liver, or 3 or more. Also remember that we tend to hear a lot in social media about supplements. The only thing that will cleanse the liver is the liver itself. We normally do not recommend any other type of supplement apart from caffeinated coffee, as we know that many of these supplements tend to have additives that actually can be damaging the liver and can cause liver failure, which we have seen here at Mayo Clinic, where patients end up requiring liver transplants due to liver failure. So in summary, NAFLD, now known as MASLD, has become familiar with the new terminology, MASLD, MASH, MetALD. Get comfortable with your patients talking about these terms. And as I told you, normalizing the terms fat accumulation in the liver. Remember, the patient is not obese. The patient has obesity. The patient is not an alcoholic. The patient has alcohol use disorder. Get comfortable with your patients. Make sure that they trust you to be able to talk to you about their alcohol consumption and the reason why they consume alcohol or they even eat. MASLD is expected to grow in the US and in the world. There are now screening recommendations. There's something that we can do for this big epidemic that is coming to us, and it's already here. Identify and refer patients at higher risk, as we already said, stage 2 or above, and send them for appropriate non-invasive tests. And dump the paradigm that there is no treatment for cirrhotic liver disease. Many of you have heard in the news and very important papers recently at EASL, we are hearing more about GLP-1 medications that have been able to successfully help patients to lose weight. And also we are starting to see how there are medications that can revert fibrosis, as you can see here, resmetirom, for example. But remember, if we do not change the base of all of this, that is lifestyle modifications, and we start treating patients with medications, we're not going to get anywhere. If we discontinue these medications, the studies that have been published have shown that the patients regain weight. Obviously, those that were on GLP-1s regain weight lower than patients that were just following lifestyle modifications. But it's very important to educate our patients and make them understand why lifestyle modifications are so important on top of medications like GLP-1s or resmetirom and others, for example. Thank you very much.
Thank you so much. That was excellent. Loved hearing that information. We will now welcome Justin. Justin Potter is an acute nurse practitioner at Mayo Clinic in the Department of Hepatology, Transplant Hepatology. He specializes in care of patients with end-stage liver disease, liver transplantation, MASLD, and metabolic syndrome. Welcome, Justin.
Thank you for having me. Well, Dr. Lizaola-Mayo just ruined my coffee order for tomorrow. I will be having black coffee, that's for sure. I'm an acute care nurse practitioner at Mayo Clinic. Currently, I'm wearing quite a few hats. We take care of the pre and post liver transplant patients. We do hepatology consultations in the hospital, and I see patients in the clinic that are post liver transplant. And recently, we started a metabolic clinic at Mayo Clinic just because of how prevalent MASLD and metabolic syndrome is. And we'll do consultations on those patients with MASLD and at least stage 2 fibrosis. So currently the number of patients with metabolic syndrome and MASLD is increasing, both pre and post liver transplantation. In a number of cases, patients who receive a liver transplant for MASLD often have recurrence of disease with ongoing fibrosis to their allograft, and this can lead to ongoing damage and results in end-stage liver disease once again, to where they need to be reconsidered for retransplantation. So we're really trying to mitigate the complications of metabolic syndrome pre and post-transplant for our patients. And that's where this initiative comes in. We get a chance to counsel patients on weight loss, exercise, healthy eating, and intervene with medications and/or surgical intervention. We often use expert service lines to help improve outcomes. We'll have various options like a dietitian referral. We have a fatty liver class, psychiatry, endocrinology, bariatric surgery, or even endobariatric surgery. The outcome that we're looking to achieve is either reversal of their fibrosis or at least stability. We don't want them to progress to having cirrhosis once again and decompensation, needing a liver transplantation. That's the thing that we look for most from the transplant team perspective, but I'll tell you all parameters of metabolic syndrome, if we see improvement in that, that's even better because we know that it'll help to limit the complications related to that disease. So I briefly want to go over metabolic syndrome and MASLD. I don't think I'll be able to top Dr. Lizaola-Mayo, but it's nice to hear it from different perspectives and hear it over and over again so that we can get it kind of nailed down into our mind and be able to explain this to patients. Metabolic syndrome, simply put, it's a cluster of conditions that occur together. They increase your risk of heart disease, stroke, type 2 diabetes, MASLD, and many other chronic conditions. These conditions include high blood pressure, high blood sugar or diabetes, abdominal obesity, and abnormal cholesterol, specifically high triglycerides and low HDL. The exact cause of metabolic syndrome is not known, but factors like insulin resistance, obesity, physical inactivity, and genetics definitely play a role. Lifestyle changes like healthy eating, regular exercise, weight loss, quitting smoking if they're a smoker, and can help manage metabolic syndrome and overall reduce the risk associated with the complications of metabolic syndrome. So MASLD, it's as you just got a great overview of that. It's a term used to describe liver conditions characterized by an accumulation of fat in the liver or steatosis that are associated with metabolic syndrome. It encompasses a spectrum of liver disorders ranging from just simple fat in the liver or steatosis to metabolic associated steatohepatitis, which involves inflammation and liver cell damage and can progress to cirrhosis and liver failure. We know that MASLD is strongly linked to obesity, insulin resistance, type 2 diabetes, dyslipidemia, and hypertension, all of which are components of metabolic syndrome. The exact mechanisms linking these conditions are complex, not fully understood, but it's believed that insulin resistance and inflammation play the most significant roles in the development and progression of MASLD. Management of MASLD typically involves lifestyle changes such as weight loss, dietary modifications, regular exercise, and controlling those risk factors. In more advanced cases, medications and interventions to help specific aspects of the condition may be necessary. Statins, antihypertensives, weight loss medications. And overall, it's important to know that early detection and intervention are crucial in preventing progression to more severe liver disease and the other complications like an MI or a CVA or other chronic conditions. You know, daily, what I see, we follow our patients in the clinic for life after they receive a liver transplantation. We see them at least annually to ensure that their transplanted organ is doing well. Within that eval, we like to understand how they're doing metabolically. So we get a lipid panel, we're checking for hypertriglyceridemia, low HDL. We get glucose or A1C, measuring their waist circumference for abdominal obesity and blood pressure. That's all part of the visit. Knowing that immune suppressant medications that we put patients on after an organ transplant, they increase the risk of all of those things. So you're more prone to hypertension, dyslipidemia, type 2 diabetes, and obesity. They pretty much add fuel to the fire for somebody that has metabolic syndrome already, or they are more susceptible to developing it. We often prescribe medications to help control metabolic syndrome, but we rely on endocrinology if the patient's a diabetic and treatment of that. And we also encourage patients to utilize their primary care provider to help with blood pressure, obesity, or abnormal cholesterol panel. You know, what I hear from patients sometimes is difficulty with finding a PCP that will manage a patient that is post-liver transplant. And I just want to, express that we really shouldn't treat them any different than the general population in the community just because they've had an organ transplant. Treating their blood pressure is totally fine, their obesity or their cholesterol panel. we've pretty much nailed into these patients that if they're starting any new medications, that they should just run it by us, because there are some of those medications that can react with their immune suppressants. But otherwise, we should be treating these patients just like any other patient in the community. I think we all need to be able to work together in a collegial way to achieve the best outcomes for our patients with the various specialty providers. In the metabolic clinic, we're getting referrals for those patients, as I said, with MASLD and stage 2 fibrosis. I go over a lot of the same things as I do with our post-transplant patients in the metabolic clinic. First, I educate them on the condition and how this happens. Many of the patients have already been primed, so to speak, but it helps to continue to hear these issues from different providers in various ways so that they can start to comprehend the condition a bit more and know how to tackle it. I discuss metabolic syndrome and discuss if they have the condition, what abnormalities. Remember, it's 3 of those 5 things. Low HDL, high triglycerides, abdominal obesity, type 2 diabetes, or hypertension. 3 of those means you have metabolic syndrome. And overall, I would argue if you got 2 of those things or 1 of those things, something's kind of tipping the wrong direction metabolically. I like to assess their motivation and readiness for change, find out how important improvement in these conditions are for the patient. It's important to find out where they are in this process. Have they even contemplated making a change? Are they preparing to make a change? Have they taken action? Have they already taken action and been successful and they're now on a maintenance phase? Like to ask what diets, medications, lifestyle changes they've tried, how long were they successful, what barriers were in their way of accomplishing their goals. I will rarely prescribe weight loss medications at a first visit. I want to get to know them, assess their readiness for change, and come up with some achievable goals for them. Things like following an exercise regimen, following a hypocaloric diet, we try to make goals for weight loss and calorie restriction. If they are successful and I feel like that combining weight loss medications is going to help them, I'll add them, and I like to have the patients start to change prior to giving them a medication that is helpful for most. I think that this is how they'll be the most successful, and they get a sense of accomplishment prior to that, and they can hopefully promote long-lasting change to their diet and exercise regimen. Also, I've determined that weight loss medications I need to determine, is it weight loss medications that we go to, or do they need surgical intervention like endobariatric surgery or bariatric surgery, which for some patients over a very high BMI, that may be the best route to go. So that's kind of my take on things, my day and how things go. And I really appreciate you guys having me here today and getting the chance to speak with you. Thank you.
No, thank you so much, Justin. Your information was great. I think especially for the majority of our audience are nurse practitioners, so to hear from you is excellent. We would now like to welcome Sheena Gillani, who is a gastroenterology and hepatology fellow from Rush University Medical Center. Welcome, Sheena. Oh, you're on mute.
There you go. Hi, everyone. I'm going to just pull up my PowerPoint really quickly. Okay. Just fix this screen really quickly. So today I'm going to discuss how we can culturally adapt the Mediterranean diet for Hispanic and Latino patients with MASLD. So we've already had a great discussion about SLD, so I'm going to skip through that. And we already talked a lot about the background in epidemiology, but I just want to highlight again how crucial it is to identify patients with MASLD, especially because it can be reversible. And there are tons of ethnic disparities in MASLD globally. Like we discussed too, in Latin America, 44% of patients or of the population has MASLD, which is almost 1 in 2. And there's significant ethnic disparities in MASLD within the United States as well. So using the new nomenclature, a group of researchers looked at 4,000 patients through the NHANES surveys, and those 4,000 patients represented around 199 million adults. And what they found was that in the Hispanic population, in almost every single one of these SLD categories, they had the highest rates. And interestingly, what they did too is when they broke down the Hispanic population into Mexican American and other Hispanics, and they found that the Mexican American patients had even higher rates of all the different SLD categories compared to the Hispanic and Latino population in general. So this is a really important population to identify this in and to work with. And what we also saw in the Hispanic population is that they're also high risk for MASH and advanced fibrosis. So why do these disparities exist? So we already talked about how genetics like the PNPLA3 gene doubles hepatic fat content compared to the general population, and a lot of the lifestyle factors as well. They're very high risk for metabolic syndrome, but also there's a lot of the social determinants of health that play a large role too. So in this first area, I have the Hispanic and Latino population, and then the second one is the non-Hispanic whites. And as you can see, the unemployment rate, food insecurity, less education, no healthcare access are all higher in the Hispanic and Latino population, unfortunately. And this all plays a role in, obesity, diabetes, all these other factor developments. And with the genetics, it's just a very vicious cycle and combination. So how do we treat MASLD? We had a great discussion about that already, but there are medications now that are available like Ozempic. Rezdiffra is one of the first FDA-approved medications for MASH for like F2 and F3 fibrosis, but lifestyle interventions are still the foundation and considered the gold standard for treatment. And additionally, having that weight loss of 5 to 10%, and ideally they do that through a 500 through 1,000 calorie reduction, that's when you really see the reduction in steatosis and fibrosis. And a lot of people ask about dietary or different diets, what's the best macronutrient distribution? But a lot of studies have shown that it's really the calorie restriction and achieving that weight loss goal of 5 to 10%, that's really the best. So this is just a very brief overview of the different type of diets that a lot of our patients ask about. Everyone loves the keto diet. It gives you great results. You lose weight very quickly, but it's really not, and you do see a reduction in fat, but is the reduction in the steatosis because of weight loss, or is it because not eating carbs causes the improvement in steatosis? The studies are still out there on that. So, and it's also really hard to sustain over time. So we don't recommend the keto diet. High protein diets are really popular right now too, and we do see great results and great benefits with them, but there are some amino acids that actually cause de novo lipogenesis, which is a pathway that increases the steatosis in the liver. So there's still not enough data to recommend this in good faith, so we don't recommend it right now. The paleo diet, also a lot of people are seeing great results and a reduction in steatosis, but is it because paleo is inherently beneficial, or is it because they're eating a lot of good fats, a lot of protein? We're not sure if cutting out dairy, grains, and beans is really the cause for improvement in hepatic steatosis, so we don't recommend that. Intermittent fasting, there's so many different definitions and ways to intermittent fast, and we are seeing a lot of benefit, but we're thinking we're seeing this benefit because of the calorie restriction that leads to the weight loss. So we aren't sure if it's the weight loss or the circadian rhythm or kind of both, so we don't have enough information to recommend that for MASLD. What we do recommend, though, is a Mediterranean diet. It has been shown to improve insulin sensitivity, glucose metabolism, cardiovascular disease, cancer risk, practically like everything, and it reduces hepatic steatosis too without that weight loss. So we feel like we have a good enough information to be like, okay, this is actually inherently reducing hepatic steatosis. And so it's recommended by US and European Liver Association for MASLD. So oftentimes, whenever people think of the Mediterranean diet, they think of things like grilled meats, couscous, hummus, olives, feta, which are all great foods. But if y'all walk away with anything from my presentation, I want y'all to know that the Mediterranean diet can be any cultural cuisine. It can be South Asian, it can be African, Mexican, East Asian, it can even be American. And so the Mediterranean diet is just a list of guidelines that people should follow. Mostly it's reducing the amount of processed foods, which will have saturated fats and trans fats, reducing red meat, a lot of these simple sugary things like sugary foods and sugary beverages, and really increasing the poly and monounsaturated fats. There's a lot of studies about olive oil specifically. That's the main fat that the Mediterranean diet recommends. It has oleic acid, it has tons of different health benefits and properties. So that's one of the biggest things for the Mediterranean diet, recommending olive oil and eating a lot of nuts. Also recommends a lot of complex carbs rich in fiber and a lot of protein from lean white meats, seafood, especially fatty fish, and plants. So every component of this diet is customizable, whether the types of food, the macronutrient distribution you want to do, the timing you want to eat. And a whole group of researchers and experts went to this international consortium where they developed the Mediterranean diet pyramid, which I absolutely love because it just takes a lot of the food groups and tells you what you should be eating with every meal, every day, and then weekly. And so you can literally throw any type of food into these food groups and associate it with any cultural preference. But the main important thing to remember too is that everything has to be portion controlled as well. So ensuring that patients know that half their plate needs to be fruits and vegetables and having the right proportions is important. So what everyone should be eating for every meal is 1 to 2 servings of whole grains, and we have a lot of culturally relevant whole grain examples, and then having 1 to 2 servings of fruit with each, or fruit or vegetable with each and every meal, and it's a mix of cooked and raw, and we have a lot of culturally specific fruits and vegetables, daily extra virgin olive oil, along with nuts and seeds, and staying away from like margarine, palm oil, coconut oil. Having 2 servings of dairy a day. You can do low fat. I've seen other groups with the Mediterranean diet do full fat as well. It's kind of just based on your population, but at least this consortium recommended low fat. Spices all the way, just decrease the amount of salt, but you can use any spice. And beverages focusing on water, black coffee, unsweetened tea, seltzer water, infused water, and then all the cooking methods practically besides frying. And then weekly, they recommend lean meats and plant protein. So they have very specific guidelines on how much fish, white meat, eggs, and beans. They also just recommend decreasing the amount of potatoes. They included potatoes in the meats and plant protein just because a lot of people eat meat and potatoes. So they just thought that would be a better place for it. And then also decreasing the servings of red meat and processed meat. And I want to highlight too, they don't say never eat red meat or never eat processed meat. It's about making sure you enjoy life too, but also reducing it in your everyday life and saving these foods for special occasions or treats at the end of the week. Also, again, recommending sweets in the same way in small amounts and reserved for special occasions. And the Mediterranean diet technically recommends alcohol. It's not a requirement. It's to drink socially. And these are the maximum values for people in the US. But with MASLD, we don't recommend alcohol. So what we did was we created example recipes for patients using culturally relevant foods. So we have a recipe for Mexican-inspired oatmeal. We have recipes for spicy and tangy fruit cups, which have a lot of different spices. This is my favorite. I make this at least like twice a month. Tofu mole bowls. You can do it with chicken. You don't have to do tofu, but we have a healthier recipe for mole that still retains the flavor and the cultural relevance to it, but it's a lot healthier for you. And then we have something like chicken chili verde. So we've just customized a lot of these recipes for our patient population just so that it sparks an interest or an idea that, hey, I eat these foods at home and the foods I eat can actually be healthy as well. I just need to make a couple modifications and this could be considered the Mediterranean diet. And so we have some infographics for our patients too. I just copied a couple of them, but replacing flour tortillas, with egg white wraps, you could do low carb tortillas. Some people like the kale, chard, romaine leaves. I know that's a little bit of a harder sell, but it still works. And then white rice, there's tons of great options. You can do brown rice, you can do portion quinoa, cauliflower rice, miracle rice, white veggie rice. And we don't tell patients stop eating white rice fully, especially if they love it so much. We're like, do half white rice and mix it with half cauliflower rice and then slowly, start changing it a little bit more. But it's good to know the different types of replacements and the calorie differences and the fiber differences. So this is what we recommend. And of course, it's not just about diet, it's about lifestyle. So it's really important to incorporate family. You stay motivated by having your significant other or your kids be involved with cooking or having friends over. And then like meal planning, cooking at home. Sometimes we recommend replacing a meal with a protein packed smoothie to keep people full and to help with that calorie restriction. There's so many great apps right now that help you with this, like MyFitnessPal and Noom, that help you stay accountable for the calories you're eating and the foods that you're eating. And then following with an interdisciplinary healthcare team, if that's available to you. And of course, stopping smoking and incorporating exercise into your daily lifestyle. So a lot of people, ask me, why culturally adapt this diet? How is this going to help? And what I found is that it's really hard for many families to get buy-in from other family members to cook new healthy recipes. So oftentimes what happens is the person who's cooking cooks a meal for themselves and then cooks a separate meal for everyone else. But if we can customize the meals that they're already eating to follow this pattern that we know has so many benefits, it's going to really allow other family members to buy in. It's because you're eating the same types of food, you're just tweaking it a little bit. The taste may be different, but it still hits pretty close to home. And a lot of studies have shown that that actually providing healthy recipes to patients saves time and energy, so they don't have to go to the internet, search for things, decide if it's healthy. Just providing them with healthy recipes is really beneficial. So Rush University Medical Center also has our own weight loss intervention program for liver disease. It's called the WILD Clinic, and it's a clinically proven weight loss program for MASLD patients led by our wonderful APNs at Rush. So far we have 72 patients. This is a little bit about their stats, and our goal is for a 5 to 10% weight loss. So our average weight loss, we're pretty close. We're at 4.8%, but there is this discrepancy between the Hispanic Latino population and the non-Hispanic white population. And when it comes to greater than 10% weight loss, there's an even bigger discrepancy. Although these weren't statistically significant, it kind of encouraged us to find ways to reduce this gap. So we're hoping to provide these recipes to our patients to see if, having culturally relevant recipes is helpful for them towards their weight loss goal. So thank you everyone so much. These are my mentors at Rush University, and so I just wanted to give a special shout out to them, and thank you for ALF for having me talk with y'all today.
Wow, that was absolutely amazing. Thank you so much. That was fantastic. I think my key takeaway from everyone's presentation, lifestyle changes. We're now going to bring back our panelists for a few questions. I think the interesting thing is that we received about 10 questions prior, and you guys answered most of them. So that's fantastic. You guys are on point. But one of our questions is, what is the screening tool to assess for risk of developing cirrhosis? Anyone want to answer that? Justin, Blanca, Sheena?
Can you repeat that real quick? The screening
Absolutely.
tool?
So Tracy asked, what is the screening tool to assess for risk of developing cirrhosis?
I mean, I don't know if there's a screening tool developed for the risk of developing cirrhosis, but you can start to see the progression. So, if somebody already has steatotic liver disease, I think Dr. Mayo had talked about an MRI or a fibroscan or a liver biopsy to kind of determine where they're at in their stages of fibrosis. I think, the worse their metabolic syndrome is and the worse control we have of those risk factors, that to me would signal they have an increased risk of that rapid progression that Dr. Mayo was talking about.
I agree with Justin. The only thing that I would add is that for those patients that are at low risk, meaning that they do not have advanced fibrosis at the time that we screen them, even though they're going to continue to follow with their primary care physician with lifestyle modifications, etc., we need to remember that we need to continue to screen these patients moving forward, right? So any patient that has, for example, type 2 diabetes or more than 1 to 2 cardiometabolic risk factors needs to have a FIB-4 every 1 to 2 years. And if the patient doesn't have diabetes or doesn't have cardiometabolic risk factors, this can increase to 3 years.
Thank you for that. Someone wanted to know, when people are screened and found positive for liver disease, what are the next steps a provider should take? Blanca, you want to take that?
Sure. So if the question is when a patient has liver disease, what are the next steps to do?
Yeah, that a provider should do, primary care provider.
So I know that we're talking about MASLD, but we need to remember that there are a wide variety of things that can cause liver disease. So normally the way that they come to clinic is patients that have elevated liver enzymes or are found to have hepatic steatosis in an ultrasound or any other cross-sectional imaging that they had for other reasons. We need to keep our mind open, right? So we need to first remember that we need to rule out any other potential liver diseases, as we already talked a little bit about viral hepatitis, for example. We still see hepatitis C every once in a while. And, it still blows my mind how we have been able to find the cure for hepatitis C. And we are now transplanting patients with organs that are hepatitis C positive. And then we treat the patients after transplantation for 12 weeks and then they're cleared from hepatitis C, which is amazing. But anyway, I'm deviating. So normally the first thing is, one, try to understand better why the patient has elevated liver enzymes. Number two, see if the patient has advanced fibrosis, as we already discussed. And three, if there are any potential, for example, supplements that we see very frequently or medications that can potentially be causing elevation of the liver enzymes. So the workup is extensive, but what I would say is that in the setting of primary care, what I would normally recommend is to repeat the liver enzymes in 3 to 6 months to see the trend and try to find if that patient has had elevated liver enzymes in the past. Remember that not because the number is not red means that the liver enzymes are not elevated, right? As gastroenterologists and hepatologists, and Sheena can confirm this, like normally in patients, in women, for example, I like seeing those liver enzymes in women less than 20 or definitely less than 30, and in men, the same thing. Like the ASLD or our guidelines recommend that we need to make sure that in men, liver enzymes are less than 30 and in women less than 20. So important to take that into account. So it's a combination of things, right? You also need to make sure that they don't have any relatives with liver disease. And for example, in the setting of hemochromatosis, if you diagnose a patient with hemochromatosis, you need to make sure that the relatives are screened for hemochromatosis.
No, absolutely. Dr. Sheena, one of the topics that you mentioned was children having fatty liver disease, having MASLD, and that's something that is increasing. What can a provider do and connect with the parents to support that child?
You know, I actually haven't worked with many children who have MASLD. This might be a better question for Dr. Lizaola-Mayo. Sorry.
You know, I also do not see children, but what I can tell you is that many times I see children in clinic that come with their parents, and I can start seeing a trend. And what I communicate with them, just like to their spouses or siblings that come with them, is like, this runs in families. And we already talked about it. The fact that I'm Hispanic really helps to establish that relationship and same tone where I have kids. The environment where we live is obesogenic, right? We know that we are surrounded of fast food, that everything's easier. Our kids are not exercising as much as before. We need to start making little changes here and there, right? So educating them that kids do not need, for example, obviously energy drinks, but high sugar content like drinks, like juices or things like that. They need to stick to water. Why do kids, need to be eating so many candies, for example? So really starting from there, from home, right? How do we teach our kids how they should be eating? Why shouldn't they not be spending, so much time on, watching TV and probably, go out and play? Probably not here in Arizona because it's 110 degrees right now. But things that they need to change, right? Like the education starts first from the patient. And it's really interesting how after follow-up visits, when it clicks, right? That last time modification clicks, they start spreading, within the family why instead of eating X, they start eating, healthier options. So normally that's what I recommend.
Okay. And connection to that, Sheena, this particular question, and someone did have a question about this, what can we recommend to our patients to drink besides water?
I know water is the best, but what I recommend too is you can do fruit infused things. So like lemon or lime, freshly squeezed in water. Some of these seltzer waters are really great, like the LaCroix and bubblies that don't have any additional sugar. Unsweetened teas are great too. There's so many different types of teas that you can drink that have a lot of flavor in them too. So, and then black coffee, of course, but I know it's really hard to get away from the sodas and the fruity drinks. Even for some of my patients who are really addicted to Coke, I'm like, at least start with Diet Coke first. Let's go to at least the 0 calorie, and then we'll start working on getting you off the Diet Coke. But that's also another option and alternative.
Thank you so much. And we will take a few of your recipes and share them with our medical providers so that they have that to share with their patients. We have a wonderful new program that the American Liver Foundation has called Think Liver, Think Life. And many of you can go to thinkliverthinklife.org to find out more information about our screening and our different programs within Think Liver, Think Life that really focuses on fatty liver disease, and MASLD. So now that we're coming to an end, I've just asked each one of you to give a final thought. And I think this is a perfect timing and perfect audience. Oh, wait, we do have one question that Dr. Blanca could answer that someone had in the chat. So once she answers that question, then we will go to final thoughts.
So the question is, can anyone, patients with type 2 diabetes and MASH, do you recommend Actos, that is pioglitazone? So pioglitazone is one of the first medications that was found to be beneficial for patients with before known NASH or MASLD. In my practice, to be honest, I do not use it anymore. Once in a while, the only medications that I continue to use is vitamin E, but we need to remember that vitamin E, obviously you need to make sure that you don't keep the patient forever, right? Because it has its potential side effects. Now, remember as well that pioglitazone, one of the side effects is weight gain. So that's one of the other reasons why I really do not use it anymore. And a medication that I use a lot, talking about the metabolic syndrome and how we want to decrease insulin resistance, is metformin. So metformin has not shown to directly affect or improve MASH or liver fibrosis or steatosis. However, what we're trying is the metabolic syndrome, right? Decreasing that insulin resistance that long-term will help with MASLD.
Thank you for that. We will start with Sheena, then Justin, and then we'll end with Blanca. If you can give final thoughts.
Yeah, so again, thank you so much for having me talk. And I just want everyone to remember that the Mediterranean diet can be any part of any culture, and that it's important for patients to connect with the food that they eat. They just need to make a couple switches in order for it to really follow the Mediterranean diet guidelines and for it to be super healthy for them.
Thank you for having me. I think my last thought would be that we all know that this is a very difficult subject. There's a lot of feelings, emotions, and connections that have to do with food and development of MASLD and metabolic syndrome. I would recommend that everybody try to lead by example for their patients by trying to incorporate some of these things slowly but surely into your own life. And then it becomes easier and easier to speak to your patients about changes that they can make and how you've been successful to do so.
Well, it was a pleasure, Ivory. Thank you so much for creating these amazing spaces where we all learn, right? And we all get more comfortable with this highly prevalent disease. I think I will just echo what Sheena and Justin just mentioned, right? Like, it's very important to get comfortable with number one, the new terminology, number two, with your patients and normalizing these terms and normalizing obesity, normalizing alcohol use disorder. That's where we need to start. And Rome wasn't built in a day, so these patients need to set goals, and that's something that has really helped me in my practice, where I set goals with my patients. We follow closely, and what I mentioned before, having that multidisciplinary and personalized approach is extremely important for this highly prevalent disease. So thank you all, and if anybody has any other further questions offline, I'm more than happy. Please email me, and happy to answer anything else.
Thank you so much. Thank you to all of you for a great presentation. As I mentioned, we will be providing this recording on our YouTube channel. You'll be able to find more information at www.liverfoundation.org. We would also like to thank our sponsor, Pfizer, for their support with this program, and the American Liver Foundation. And another special thank you to the National Association of Nurse Practitioners and Women's Health. They are a great partner, and we really, truly could not have done this without them. And you can find more information about them at www.npwh.org. Thank you all very much.